Hi, this is Bob Harrington from Stanford University in Medscape Cardiology, theheart.org. Today, what I really want to talk about is this idea of how often does myocardial inflammation, myocarditis, occur in athletes? What should we be worried about in athletes who have had a COVID-19 infection? What are some of the screening tools we can use to guide our recommendations and the conversations that we need to have with patients and their families? And what are the latest data tell us about what's the incidence, how we approach this, and how importantly, the question that all athletes want to know, they can get back to doing the sport that they love and that they excel at. So I'm really privileged today to have with me my really good friend and colleague, Dr. Manesh Patel from Duke University. Manesh is currently the Richard Sean Stack Distinguished Professor at Duke. He is the division chief for the Division of Cardiology in the Department of Medicine at Duke, and he is the co-director of the Duke Heart Center. Manesh, it's really a pleasure to see you on the screen here, and I can't think of a better person to help with this, given your background of training both in clinical cardiology as well as in cardiac MR. Even all the grief I used to give you when you were over in the MRI scanner instead of the cath lab, this is the time it's really paying off, isn't it?
Yeah, no, thanks, Bob. As you said, when you said think of no better person, I'm glad there are better athletes for sure, but I certainly am trained in cardiology and MRI, so I can help with that.
Yeah, they didn't pick either one of us to do this discussion based on our athletic prowess, but more because of me, because I'm willing to ask the questions, you because you actually know something. But let's kind of frame this up, Manesh, and we'll do it in what I'll call a temporal fashion, because it's been in some ways a rapidly passing year in terms of knowledge accrual, but in other ways it's been a tedious year as the year gone on. But when COVID first came onto the scene last late winter, early spring, one of the things that I think a lot of us in cardiology was struck by is when we saw the early reports, case reports that were coming out on the cardiac involvement of patients who had COVID-19. And now I'm going to say, not talking about the myocardial infarctions that were observed, not talking about the strokes that were observed. That's something for another conversation, the thrombotic complications. I want to talk to you about the inflammatory complications, particularly myocarditis, which was, I think, something that raised a lot of antennas when that first appeared. What were your initial thoughts going back to last March when you saw those reports?
Yeah, thanks, Bob. And, obviously, we all realized quickly that COVID-19 was beyond a respiratory infection and that people were coming into the hospital and eventually having, at times, unfortunately, cardiovascular collapse. So we recognized that they were getting very sick and having cardiovascular collapse. And there were many mechanisms by which, at least biologically, we thought, certainly with something that binds an ACE2 receptor to vascular endothelium, it could affect the heart. And so there's early reports, I think the first MRI study coming out of Germany that had over 100 patients that had left the hospital where they did MRIs and found abnormalities on MRI, which quoted, 60, 70%. When that came out, I think two things happened for at least me. I looked very carefully at that study and thought, there is clearly some pictures and some people in here that have myocardial involvement. There were also several people when I looked at the images and other things where I thought, I couldn't tell if that's actually myocardial involvement from COVID. Is that something they had? They're 60 something and they've had cardiovascular disease that's unknown. And some of those, let's say, findings are very sensitive. So, immediately there was a concern that there's myocardial involvement. And then the second was, how are we going to actually sort this out to help inform our colleagues and our patients?
Yeah, and it's a classic issue in imaging of all types, but we're focused on cardiovascular imaging here, is that what happens when you pick up stuff that you didn't know that you were going to pick up or that you didn't anticipate picking up? How do you deal with that information?
Yeah, it's a constant thing in all of medicine and certainly in cardiology where I'll call it screening for evaluation of some involvement. Remember, because obviously we understood in COVID that there were symptomatic and asymptomatic individuals. And certainly in that study, there were a lot of symptomatic individuals leaving the hospital. But this, as we get into the athletes, we'll start talking about how do you do evaluation in people that may be very high functioning and should you be doing screening, which is obviously a controversial topic.
Yeah, and that's a topic that we'll definitely come back to. I mean, I'm always telling the residents, the fellows, that do not get a test unless you know what you're going to do the results of the test that you're going to get because of this issue of dealing with things that might surprise you. And, as you pointed out, the Germany paper was really a broad spectrum of patients, but then a report appears, I think it was a letter to the editor from Ohio State University that pointed out in a group of competitive collegiate athletes that there was actually a high incidence of abnormal MRI findings on this group of athletes. Now, non-consecutive, not great controls, a lot of the caveats that have to be applied. But again, that raised a lot of questions, didn't it? Because of the unique nature of competitive athletics, which involve very strenuous exercise and also a return to exercise at some point. So let's again deconstruct that one, Manesh. What did you think when you saw it? And then help the listener try to understand, why would we care so much about myocarditis in athletes?
Well, certainly, Bob, I think this is a really, this is with a lot of things in COVID, this was the confluence of science, a little bit about the economy of how universities and programs must work, and then making sure we protect our people, our young athletes who may not always have protection. And I have to give tremendous credit to the investigators at Ohio State who published a research letter in JAMA Cardiology, rapidly agreeing to screen their athletes and evaluate those with COVID and doing a cardiac MRI study that raised awareness to say that these athletes were having abnormalities. And in fact, that original publication, I think, as you highlighted, had, I think, 26 consecutive athletes across multiple different sports that had cardiovascular imaging and demonstrated, at least using something we call the Lake Louise criteria or some of these others, where we look both at T2 and T1 weighted imaging. Just for those at home, that's looking at the water content. When you get inflammation in the cells in the myocardium might change how much actual cells and water content's there. And then looking at something called late gadolinium enhancement, where we give contrast in to see if there's actual cellular membrane damage or fibrosis. And so what they identified was 4 out of those 26 individuals had findings that were concerning for myocarditis. And so that in itself was at least a higher possible rate than one would have imagined for COVID positive people. And remembering that these athletes, young individuals, as we've learned with COVID-19, may not have a lot of symptoms. And so that was important. And then getting them back to play, right? So we know that if somebody has, in the athletic world, myocarditis, because of autopsy studies and others where sudden cardiac death risks exist, that we often want to have people, usually now remember, those were either sudden death or symptomatic individuals, where we know that we usually keep them out of athletics for 3 months or so to see how they return.
Well, let's talk a little bit about that. For our casual listener, maybe not the cardiologist is thinking about this, but let's say the primary care doc who is doing a lot of the screening for sports teams, both at the collegiate level, the high school level, et cetera, maybe even younger. Why care about myocarditis specifically in athletes? What's the risk?
Yeah, so at least our understanding is that as the myocardium gets inflamed and the cells themselves are, let's say, inflamed, that the myocardium may have 2 things. One is the ventricular function may change. So even though the person's actively exercising, their sympathetic tone goes up and down in these young athletes, and they may get an arrhythmogenic effect, and they may have something like a very scary sudden cardiac event that can lead to an arrest. And so we that's the thing we fear most in athletic evaluations is there a substrate? Is there an underlying mechanism by which somebody could have an event? And when we, before COVID, looked at series of people that had certain cardiac events, somewhere between 5 to 10 to 15% of them might have had myocarditis underlying it. And that's led to broad recommendations. However, as I've told you, one thing we've learned with COVID, and as we're learning with athletic evaluations, is there's a lot of opportunity. And I'll just say, partnering with some of the leaders in the field here that we'll talk about in a second, there's an opportunity to better define how we make these shared decision-making, both with collegiate pro athletes, but certainly parents and high school kids and middle school kids that we're all worried about and working about, including our patients and our weekend warriors that we deal with.
Yeah, I mean, that's what really struck me is that, if you look at the AHA scientific statements on myocarditis, it says that you should avoid strenuous exercise for upwards of a couple of months. Now, Manesh, that might be okay for you and I. We'll have to skip riding the Peloton for weeks to months. But we're talking about young people who love their sport, who are important to their teams, et cetera. So you want to make sure you get this one right, don't you?
Yeah, and I'll just highlight, I've had the pleasure of working with Aaron Bagish at Harvard and John Dresner and Kim Harmon from University of Washington. They've highlighted, along with a bunch of other team docs and people at our own institution, that it's not just physically affecting our athletes who don't get to play. Obviously, there's a huge psychological effect on people who've trained and exercised their whole life. And then there's actually deconditioning. And we're also recognizing there may be things like postural orthostatic tachycardia syndrome as you stop working and exercising in these young individuals that have an autonomic system that's pretty revved up. They have a volume issue that happens when you don't exercise. So now we're seeing post-COVID postural orthostatic tachycardia syndrome. So my sense is it's a very significant decision to hold somebody out of sports, just like it's very significant to not let them go to school. And so we really want to be as evidence-based as possible.
Yeah, I think that that's really well summarized, and that's why I say you definitely want to get this one right. Now, part of getting it right goes back to something you said earlier about the incidental observation. What I was struck after the Ohio State report, which I agree with you, kudos to them for putting that out there. But then several months later, we start to see appearing in the literature autopsy data, including there was a terrific pooled autopsy study that was published that said, well, wait a minute, when you actually do, again, non-selected, because these are people who happen to have autopsies after COVID-19, the incidence of pathologic examination and diagnosis of myocarditis was actually really low, like nowhere near what the imaging might have suggested.
Yeah, so just, as often is the case, first reports, case reports, and as you get bigger, you get to hopefully the closer to where you might have the incidence. So in the German study, it was some abnormalities on MRI in 60-some% of the individuals, very worrisome, right? And the collegiate athletes who you would assume had no other baseline myocardial involvement because they were collegiate athletes, although some certainly have abnormalities, we know, it was 10, 15%, 15%, 4 out of 26. And then you look at the autopsy series and you quickly get to less than 5% broader groups. And now you're looking at the gold standard. So some about the test you're looking at, some about the group of patients you're looking at, and then some about how you actually might think that incidence is. And we'll fast forward in a few and talk about some of the more recent studies. But I think what we know is that it is obviously something that is occurring. The exact rate of what it's occurring seems probably to be lower than those initial studies. But given the consequences, the questions have sort of focused on, okay, so what do you do to clear people and make sure that they're okay to do some of these things, because we want to be as safe as possible.
Yeah, that's what I want to get into. As you know, I'm an obsessed Boston Red Sox fan, and many of the people that have listened to me for years will agree with that I'm obsessed. But as you know, one of the Red Sox starting pitchers, Eduardo Rodriguez, was held out last year because he actually had what sounded to be symptomatic cardiac event and was reported as having cardiac involvement. I'm assuming it was myocarditis. They hadn't given us a whole lot more detail than that. What I'm particularly interested is he going to be back on the mound this year? And I'm going to get you to help me think through that right before we exit the program here. So, another piece of interesting data is that, as you know, with the AHA, we put together a COVID-19 Get With The Guidelines registry. And James DeLermos and others presented at sessions, of which you were the vice chair, the first report from the registry. And in that, which is mostly symptomatic or obvious reporting in the EMR, what did we see? About a 1.5 to 3% incidence of myocarditis in the HA registry?
That's exactly right. And I think this is something we're going to hear over and over. If you ask me, what do I think the actual incidence is going to be? It's probably going to be somewhere in there. And remember, these were very symptomatic individuals that were hospitalized with comorbidities that had myocardial involvement based on echo and other findings. Really well done, quickly stood up by the American Heart Association and found that the incidence of myocardial involvement of some sort was around 1.5 to 3%. And depending on whether you called it pericardial effusion, myocardial, a variety of different definitions, but things that I would worry about for our patients. So the thing that I highlighted for you, I think, as we were talking earlier, is that, we've learned these things in COVID. We don't know as well. The best I could find when I did the literature review for influenza was there was about 0.8 to 1.2%, Bob. So, we haven't, and that was out of a total of 800 cases. So if you said, what's the relative rate that happens when you have infections of any sort that can lead to myocarditis, right? But Parvo B19, a variety of ones have been described. So I think this rate might be higher given the mechanism. I think it is obviously significant because of all the other things COVID-19 does. And obviously, it is also so prevalent right now in our society that it matters so much. But I think that gives us a perspective. Now, the other thing that's worth thinking about is that the prevalence of myocarditis in individuals may be different based on whether or not you were hospitalized versus, let's say, you're an asymptomatic person, as we're starting to think about past or long COVID, who continues to have symptoms, who may have not been hospitalized. There may be a prevalence in some of these younger individuals who have different immune systems. So certainly there's a lot of biology that we don't fully understand yet for this.
Yeah, and your flu comment is so spot on that if you look at the point estimate and the confidence intervals that you just gave me, and the point estimate and the confidence intervals of COVID, they'll overlap given the state of the data today. And so one of the things I think that rightly people have been calling for, okay, is to make sure that if you're going to do these long-term registries, we got to have other groups, truly, non-infected people. We got to have people with other comorbidities. We got to have people with other viral infections or just other infections. So there's still, as you say, a lot of unraveling the biology that we have to do.
Yeah, for sure. And I guess I would say that it's both biologic and building these registries. So as I highlighted, I think some of my colleagues that I mentioned have been working with the American Sports Medicine group that has quickly stood up with Aaron Baggish, again, John Dresner and Kim Harmon and others, a group of collegiate universities, 42 or so, that have participated in putting athletes' data together. And with the AHA, I see that becoming a long-term registry of athletes that initially was started, of course, to answer the COVID question, but answer some of these others. What are the rates of abnormal things in athletic hearts, and how do you do shared decision-making for people that want to participate in sports, and how do we learn that for all the way from high school to older adults? And so I think that's a big step forward. And as you said, one of the things that we've learned in COVID also is, what's the control group? How do I compare this information? And so we're also thinking about that for a study we're doing called Hearts of Athletes, where we hope to get athletic individuals who haven't had COVID and image them so that we have COVID, control groups. And I know Vanderbilt and some other universities have also done this, had large cohorts of both athletes with COVID and without, and started to compare those images to get to a better sense of what's the abnormal findings.
Yeah, and I think, as you've rightly said as well, we're going to get information that may well be instructive here for the non-COVID related conditions, because in the control group, there may well be issues that emerge. Well, let's kind of get to the last part of the conversation, and that is the most recent data that was published last week, also JAMA Cardiology. JAMA Cardiology has done a good job of really pulling in these papers on the cardiac imaging issues related to COVID. And that was a paper also by Martinez and colleagues. It included Aaron Baggish and many of the other authors that you've referenced. And this is really focusing on a very specific group. These were professional athletes who were enrolled in protocols if they were infected with COVID-19 that involved ascertainment of symptoms. It involved, as you said, the big three. Is that what you called it?
It's interestingly, they're calling it the triple screen. Everybody in the ER docs think of a different triple screen. My athletic colleagues think of it, but they've sort of early on in the pandemic, our sports cardiology and our team docs and our sports medicine physicians came together and said, outside of symptoms, an EKG, a troponin, and an echo seemed like a good 3 tests that you would get. And if 3 of those were normal, what was the likelihood you were going to have something really abnormal in this person? And Matt Martinez, as you highlighted, and others have done a nice job of describing in the pro athletes across several different professional sports. And again,
sports, right?
Yeah, pretty impressive, right? You mentioned the Red Sox, but also has hockey players, football players, baseball players, as you noted, so others. And men and women, they identified that the rate is like around 0.7 or so that have abnormalities. And specifically that triple screen tended to do pretty good to identify those who were going to have an abnormality. So gave some, hopefully, information to those primary care physicians and others that are evaluating people and trying to get both symptom evaluations and think about the testing we would do.
Yeah, I mean, I think they really did a nice job that if you were minimally symptomatic to asymptomatic and you had a negative triple screen, then you were able to return to sports pretty quickly as your quarantine period ran out. But for those people who had an abnormality on the triple screen, as you said, it was low, they did go on to MRI. And there are some of them who have evidence of myocarditis, but it seems much, much lower than the previous data might have suggested.
Yeah, that's the thing about this. It's definitely lower, but myocarditis is still pretty scary for people who've had the COVID infection or the SARS-CoV-2. And so, I think for especially younger individuals who are so functional at baseline, and certainly athletic individuals, I think the idea of making sure you get a good symptom screen and then making sure you get some evaluations valuable. And with that same group of authors and others, as I've said, we've put together a fairly large collegiate example of trying to do this. And I think, that hopefully that data will come out soon too, but we'll be looking at some of the same kinds of things. What's the testing? What's the constant long-term symptoms? And what were the number of individuals that had MRI findings? I also think the Big Ten has done a job of making sure they MRI'd everyone that was going back. So they're probably going to publish a larger series that'll give us a better point estimate. But at the end of the day, I think the clinician's going to be wondering, okay, so I'm in clinic, and I have the 16-year-old high school soccer player come to see me, and what should I do? And I think outside of understanding their symptoms, doing some of these tests that we just described, this sort of ECG, symptoms tracking, and then maybe a echo. I'm not sure you have to do the troponin in that individual. It's not easy to get back. If those two are pretty normal, you should feel pretty comfortable for that individual, given the data we have. If they are abnormal, then getting near an MRI is not always easy. So thinking about how you coordinate that will be important. And then, of course, when somebody has this, or somebody's recovering from COVID without myocarditis, we do a lot of work on understanding their heart rate recovery and their ability to exercise to peak, and those kinds of things that help us understand their physical ability.
Yeah, I think that's an important statement because a lot of what we talk about, even in the person who's had frank myocarditis, is a graded return to exercise where it's very well monitored. It's slow exercise, gradually increasing the activity level. And that still may have value. And it may even have value in a formal exercise, observed exercise period.
Yeah, we've been thinking it broadly. The reason I got into this is as interested, as you said, in MRI and other things, but just thinking about the number of people we were going to have leaving our healthcare system and people we're caring for that are going to have COVID, and how are we going to evaluate their hearts, and how are we going to get them back to doing the things they want to? Sort of what I call return to play, return to work. How do you get people return to play, return to work? And that's why these athletic registries are so valuable, because they're doing it very carefully and obviously importantly for these athletes who theoretically, not that, again, everybody has some baseline abnormalities, but they're going to have less baseline cardiovascular abnormalities than our cohort of 50-year-old individuals or 60-year-old individuals that are in the hospital.
So my final question, again, as you said, to help out the primary care doctor seeing a young athlete in their office. Troponin's pretty easy if you're able to get it because it's either normal or it's not. Echo is pretty easy to get and interpret, and you're looking for wall motion abnormalities. What should they be looking for in EKG?
Yeah, it's a great point. And just to remind you on echo, a certain number of these individuals had a pericardial effusion. So,
yeah,
so any little bit of a pericardial effusion might raise your awareness, especially when you're thinking about pericarditis, myocarditis. So no pericardial effusion, no wall motion abnormality, pretty normal looking ventricle. You have to be careful what you start looking for, because you're going to see thickened septums. You're going to be wondering, do I have to start thinking about other diagnoses? So as you said, be careful when you order the test, you know how to interpret it. So asking your cardiologist to read that is important. And then an electrocardiogram, often a variety of things that go with myocarditis, pericarditis, but really, what was done in these studies is just see any abnormality. We know that athletes have bradycardia, large right ventricles. They have things that will look abnormal on ECG. So you have to be careful there too.
Early repolarization, et cetera.
Early repol is going to be common, right? So we're not looking for that as much as significant changes that might be consistent with pericarditis, or if you are actually starting to see T-wave changes that you don't think are associated with repolarization.
Yeah, and the other thing I'm looking for is, do they have any evidence of heart block? Do they have a prolonged PR? Do they have,
absolutely,
does their look a little longer than if you were lucky enough to have a prior EKG? Do it look that, as you said, the ST segments, but also, is there any evidence of AV block? I mean, you want to be, I think, very careful as you look at their EKGs.
Yeah, no, that's another thing I think that we're going to get a fair bit of data, hopefully, as these groups, like the ones I mentioned with American Sports Medicine Group or others that are carefully looking at the ECG, using the athletic ECG screening criteria versus what's different in the COVID ones to say, how do we screen? Because for a long time, there's been controversies about should you be screening athletes with ECGs or echocardiograms. So as we delve into that for our COVID, say, return to play people, I think we want to be cognizant of that available literature.
Manesh, this has been a fantastic conversation of a lot of information that's been gathered over the course of the last year. And I think, as you've rightly said, we're still learning. We've learned a lot since last March, still more learning to go. But fortunately, as you've said, people have invested in doing the right kind of research to try to understand this. And kudos to the professional sports leagues and the athletes who are allowing their data to be published so that the rest of us can learn from it. Because I agree with you. I think there's something to be learned here that goes beyond the athlete, or even if it's strictly confined to athletes, it's not just the pro athletes, it's the school, the middle school athlete, et cetera.
For sure. I appreciate the opportunity to talk about it, and certainly really, really enjoy working with a lot of our, let's say, team docs and sports cardiologists, and then a lot of the foundations and the professional societies, both AHA and American Sports Medicine, that have taken the lead here and trying to make sure we go forward and figure this out.
Well, thanks, Manesh. My guest has been Manesh Patel, the Richard John Stack Distinguished Professor, the Chief of the Division of Cardiology, and the co-director of the Duke Heart Center. Manesh, thanks for joining me here on Medscape Cardiology.
Always a pleasure. Thanks, Bob.